All right, Dr. Tarantillo will now introduce our next speaker, Dr. Sherman.
Well, it's a privilege to introduce Dr. Sherman. He's been a friend to the Nebraska Oncology Society for many years and always gives a great presentation. He's a member of Memorial Sloan Kettering Head and Neck Cancer Program. He's an international influencer in this area, and he likes the areas that I've never heard of: medullary thyroid cancer and anaplastic cancers. He's on the steering committee for the ROTG for head and neck cancer. And with that, I'll turn it over. Thank you for coming.
Hello, everyone. Thank you very much again for inviting me to this meeting. I love going to it. One, it gets me thinking about ASCO and the update, and really thinking more about the studies that were just presented. Also love hearing about the other diseases, and you always hate to follow up like lung cancer because there's like so much going on in lung cancer compared to what we seem to do in head and neck, although much bigger disease. These are my disclosures, although honestly, almost like none of these companies are really involved in almost any of the things I'm going to be talking about today, with maybe the exception of a study that Regeneron's involved with. The objective really is for a better understanding of what was presented at ASCO this year for head and neck cancer, and it's sort of its place in standard practice at this time. Usually when I talk about this, there's sort of like 4 or 5 main diseases we talk about. One is nasopharynx cancer, one head and neck squamous cell carcinoma, thyroid cancer, which is actually, sort of where a lot of my research focus has always been. And usually there's always something exciting to talk about there. Salivary gland tumors, and also occasionally for head and neck, we sometimes put cutaneous squamous cell carcinomas. Like us and the melanoma people will argue who should be covering that area. This year at ASCO, there wasn't much done in thyroid cancer or salivary gland tumors, and that's a shame. These are 2 rare tumors that for years, like nothing was ever being done. And all of a sudden, like the last decade, there's been so much interesting things coming out. But this year, really, it was not exciting, especially not for thyroid cancer. Nasopharynx cancer was sort of the main focus. There are a lot of randomized positive studies from China that came out at ASCO this year. So many that some of them were in oral abstract, but some of them also in the poster session. And I won't go through them a little bit briefly because they're sort of an interesting group of studies. Then I'm going to talk about head and neck squamous cell carcinoma and de-escalation studies. And in this case, the theme of de-escalation is very different than we've seen for head and neck cancer for many years. And while all of this is hypothesis generating and looking at future studies, there are actually pretty exciting studies in what might be coming up around the clock. And then I'm going to talk about something in metastatic, which probably is going to be the one thing that's really maybe changed some of our practices, or at least push us towards a big change. So let's start with nasopharynx cancer. So nasopharynx cancer is mainly a cancer of Southeast Asia. It's not as big a cancer in the United States. There, you'll see a little bit more on some areas in the East Coast and West Coast, but even there, it's nothing like what we see in Southeast Asia. There are hospitals in Southeast Asia that may see 1,000 cases of nasopharynx per year. I mean, to them, this is like breast cancer. These are able to do big randomized studies at looking at little details, while we aren't able to. One of the few randomized studies that was ever done in the United States was this Intergroup 009 study. This is not new. This is old data, but this was the randomized study that sort of was the backbone of our standard treatment. And this compared radiation therapy, which was standard of care, versus concurrent chemotherapy and radiation, followed by 3 cycles of cisplatin 5-FU. For a randomized study, this was in some ways a big mistake, because the reason for this is that it changed 2 variables, not 1. So 1 is it adds chemo to radiation. 2, it looks at adjuvant chemotherapy. And that was always like a little bit of criticism, because we don't know which component is more important or if both are very important. However, this study was really positive. And to sort of bring this up a little bit bigger, this had a gigantic overall survival benefit. And this is the only way we're able to do stuff in the United States. It was actually because of such a big survival benefit, the study was able to stop early, and they were able to show without question that adding chemo to radiation followed by chemotherapy should be the standard. There have been other studies in China since that time showing that neoadjuvant chemotherapy, instead of doing no neoadjuvant chemotherapy, followed by chemoradiation also leads to an overall survival benefit. So right now, when we look at standard treatment for head and neck for nasopharynx cancer, it's cisplatin radiation, and then you do either neoadjuvant or adjuvant therapy with cisplatin-based treatment. And which one's better, we just don't know the answer to. A lot of people favor the neoadjuvant approach, but adjuvant also a lot of people favor as well. So let's talk about what was looked at ASCO this year. The first is a study that was looking at about the induction chemotherapy question. So this is a very interesting study because they looked at it using cisplatin gemcitabine, which has been shown later on. This is an earlier study that was reported, but actually started like over a decade ago, where they looked at doing induction chemo with cisplatin gemcitabine versus no induction chemotherapy. What was interesting about this study, hopefully, nope, that doesn't work. Sorry, I was just trying to see if I could point. This is work? Yeah, perfect. What it showed was that, what it looked at was the induction chemotherapy followed by radiation alone. And this is the interesting thing. No one ever would think that doing radiation alone would be appropriate. Everyone really thought or thinks chemo and radiation, that most part of chemotherapy is doing it with radiation, not in the neoadjuvant or adjuvant approach. And then they compared to the concurrent way of cisplatin and radiation, which is what most of us would be considered the standard. They looked at this in WHO types 2 and 3, T1, T4, and 2 and 3. The thing is, they also looked at it in T3, T4, N0, and N1 disease. Why is that important? Well, at least in Southeast Asia, they think that group, the second group, is actually a better prognostic group and should not be included in these advanced studies. I'm not sure that's true in the US. To us, this population also doesn't, seems to do just as well or poorly as the group above. But in this study, they included both groups together. Interestingly, a lot of the studies actually limited by age. So this is not something that can be done in the US. We do not, and we shouldn't do. No, it's not that we can't do, but we also shouldn't do. The limit people to age of 65. And I think that's just, I think a lot of us think of that as wrong. We look at functional status, we look at comorbidity. We know more enough 80-year-olds that look a lot better than a 40-year-old. But here they did limit it by age. And then the primary endpoint was 2-year failure-free survival. It looked at a non-inferior margin of 10%, which also we could argue is a little bit large. You'd like to have a bit less when you're trying to look at survival. But the interesting thing is when you look at failure-free survival, it looks to be the exact same, whether you got induction followed by radiation alone versus concurrent chemoradiation. Even overall survival, if you look at it, overall survival and failure-free survival, if anything, seems to favor a little bit the induction arm, the group that did not get chemo with radiation. What made even look, and so this is an issue that really goes sort of against all the other data that exists out there. When we look at like the meta-analysis, you see the biggest benefit always being the chemo with radiation. So a lot of us have a lot of trouble with these results. It's just not consistent with anything else we believed in or what we've seen in prior studies. And the other issue at the bottom is the improvement in local regional control is really unexpected. We always believe that if we're adding chemo to radiation, that the biggest benefit there is not in distant disease, but it's in local regional control. Yet here it's actually showing that the induction arm was getting better local regional control with it. So definitely this was a very interesting study to come out. The next one is looking at this other question about concurrent chemoradiation followed by adjuvant cisplatin gemcitabine versus cis5FU. So in the metastatic setting, it is now clearly shown that while for a long time we always thought cisplatin 5-fluorouracil as the standard, both for metastatic disease and upfront, in the metastatic, they did a randomized study of cis5FU versus cisgem, and cisgem was by far superior. And this is exactly what we see in practice, that in the EBV-related WHO type 3 tumors, that gemcitabine is an extremely active drug. When they looked at the induction regimen, the main induction regimen people have looked at is the cisgem followed by chemoradiation, and that study has shown a benefit. So they're saying, okay, cisgem looks better than cis5FU. So if let's take that ALSRIF data that I did before, and let's substitute cisgem for cis5FU. And that's how they did the randomized study. So people got cis and radiation, one group got cisplatin 5FU, the other got cis and gem. One or two interesting things about this is one, cisplatin 5FU is cycled every 4 weeks in the ALSRIF data. The cisgem is given every 3 weeks. So in the cisgem arm, since both got 3 cycles, you actually finished adjuvant therapy earlier. This one they also did not include the N0, N1 patients with T3, T4 tumors. So these were considered to be a little bit of a poorer risk population than the prior study that I talked about. The results showed that the 3-year progression-free survival was improved with cisgem. And I think a lot of us expected that. And a lot of us hoped for that because we think cisgem is easier to tolerate as well. So it did show its primary outcome. What's interesting is while it showed an improvement in distant metastatic disease and it showed an improvement in local regional disease, it did not show a benefit in overall survival. Now, part of this could be is that this needs to be looked at for a longer period of time. So it doesn't mean that we're not going to see an overall survival benefit when we look at this 3, 4, 5 years later, but at least right now, there's no overall survival benefit. So you have to think about if we're not seeing overall survival benefit, is the rest of the data good enough, the benefit that we should be making this change right now or not? The next one I'm going to talk about is probably what we always want to talk about, and that's PD-1 with treatment. So sintilimab, and I know I probably mispronounced that well, it's a PD-1 drug that's not approved in the United States. And they looked at using this first with induction chemotherapy with PD-1, and then they continued the PD-1 with concurrent chemotherapy and radiation, and then continue the PD-1 after chemoradiation. So they were on the PD-1 drug for a total of a year. The standard group got the standard induction chemotherapy followed by chemoradiation. When you look at the outcomes for event-free survival, which was the primary outcome, you see a benefit. And it's a decent benefit, and the benefit comes out later on. So you could always think maybe by giving the immunotherapy, especially for a year, you're pushing events out further, which is always a possibility. But even that, like, the real benefit you're seeing as well as after the PD-1's already stopped. So you're seeing a benefit in this population. You do not yet see a benefit in overall survival, though. So still, overall survival is the thing that we're most concerned about. And you will like to see an overall survival benefit, but just like the other one, it could be that this takes more years to read out. So what do we have to say about this? Well, this is where I start getting a little more controversial and start talking about things that will make my colleagues sort of roll their eyes a little bit. And that is, there's a lot of positive studies of nasopharynx cancer coming from kind of late. And there is some concerns that we have to have about it. The main concern is, can we assume nasopharynx cancer in Southeast Asia is the same as nasopharynx cancer in the United States, even when we're talking about just EBV related? So in the United States, still a good number of it is EBV related. There are some that are EBV negative, and that's not being looked at in these studies, okay? But in EBV related ones, is it the same in both places? And the one big problem we have is that so far, all the randomized studies that have been reported have not yet been joint efforts between the US and Southeast Asia. So they're either a Southeast population or they're a US population, and very rare, like intergroup is one US population. This is the exception to this rule is going to come out eventually, and that's head and neck energy 001. That's going to be a question that's looking at EBV related marker in the blood and seeing how that changes adjuvant therapy. And that study is actually being done in the US, Canada, and Southeast Asia. So that's going to be the first time we're going to have one single study where there's going to be both populations there. So I think we'll finally have the answer. Is there a difference in outcomes? Is there a difference in response to treatment, to therapy between these two populations? But when we look at like FDA approval for anything, and the same thing for approval over in Southeast Asia, you want to see is if something that's being done in one population, does it still fit in another population? And that's the one thing we just don't know. But it's also a problem is that it's very difficult with the number of nasopharynx cancer patients we have in the US to do randomized studies here. The intergroup 099 study only came back as a completed study because it was so positive that you could stop that study early. But to do a real good study, we're talking about in lung cancer, 300 people not being enough patients to be randomized to see like this is a good outcome. That's a small study there. In the United States, you know, if we could get 200, we get 150 in nasopharynx, we're going to be putting our hands up in the air and really being thrilled. So it's not the easiest population to do a big randomized study. The other thing is this data reliable? And that's where things become a little more controversial. There have been very big concerns about, are these patients really being truly randomized? What is the quality of the data? And definitely there have been more than enough reports that many years ago, this was a big problem in Southeast Asia. We don't know if that's true still today. But like I said, some of the studies that have come out have gone really sort of against what we normally have seen. So that's the question. What I just presented, should that change how you practice against nasopharyngeal cancer? And the thing is I'm just not sure. Adjuvant cisplatin gemcitabine makes sense. You know, there is no reason to think that that is not like a real positive study, but it does not show an overall survival benefit. And for many people, have moved to induction therapy. So that showing adjuvant may not change a lot of how we practice. It may change some of it. It is a small enough move, and a lot of us think of it as a better quality of life, that people do better with cisgem than do cis-5FU. Then my guess is that most people off study will now do cisgem and adjuvant if they're going to do adjuvant therapy. And I think now we have a good excuse to do it. But at the same time, I'm not sure how much that's going to change the needle. The next thing really is adding immunotherapy to induction chemotherapy. In a lot of ways, it makes sense. Nasopharynx cancer is one of those tumors that seems to have responded very well to immunotherapy. We're not sure how the FDA is going to view it. There's been a number of positive immunotherapy studies that we've gotten from Southeast Asia and nasopharynx cancer, and the FDA has not looked at this as how good a quality data this is, and they're still looking at this data after a few years. We'll see if they make changes, but we're not sure what's going to happen. The NCCN may make these changes. They're likely to approve it from their history. The question is, should they approve it? Because this study is a very, very strange study. And what I mean by that is that we have had multiple studies of doing immunotherapy with either radiation alone or chemoradiation in head and neck squamous cell carcinomas. And not only have those studies all come back negative, the group that gets immunotherapy with radiation has actually done worse than the other groups. And there's a lot of theories about using immunotherapy and radiation because of lymph nodes when we raise the cervical lymph nodes. And it's to the point where the NCI actually is not allowing future studies using immunotherapy with radiation in head and neck, because we've had not just negative studies, but studies that almost look detrimental. Yet this study comes back positive, and that really goes against everything else that we have out there. So we're not sure really what to make of that. So the next thing we'll talk about is de-escalation. And this is something that really is interesting, what's going on. A major theme has been in HPV-related tumors. So these are tumors that do very well, is to de-escalate, because with chemoradiation, the head and neck has a lot of long-term morbidity associated with it. And so far, no randomized studies have come back yet that are positive. But at the same time, these are studies that have, a lot of early studies that have looked promising. And this is a big area of research. But at ASCO, that's not what was looked at. But ASCO was looking at the idea of de-escalation in other settings. than traditional HPV-related tumors. So the first one we'll talk about is this chemotherapy alone concept. This is an MD Anderson thing, and he got this from France. But this is, and what I'm putting up first is an old study, actually. So MD Anderson reported years ago the single-arm study in larynx cancer for stage 2 to 4. And he gave these patients this regimen, cisplatin, paclitaxel, ifosfamide, or TIP. Anyone who remembers that study is older than I am. You have to be very getting close in your retirement. It was this old regimen, only MD Anderson seemed to use it, never been shown really to be that much different, very toxic. They did a little bit of this in bladder cancer as well, but it never really went anywhere. But that was the regimen they used back in the time. And he finally reported this in 2009. So this was years later after I think they actually finished the study. But it's, like I said, it's an old study. But it was an interesting study. They gave 3 to 4 cycles of TIP, and then they did a CAT scan and a biopsy. If the tumor had progression, well, you go right to surgery and radiation. If you had a partial response, well, they tried to modify the surgery a little bit so it was function preserving. But if you had a complete response, so they didn't see any signs of disease, they gave 3 more cycles of TIP, and that's it. No radiation, no surgery. So they're basically saying, let's see if we can cure larynx cancer with only chemotherapy alone. 31 patients were on the study. Most of them were small disease. They're T2 or N0. 37% actually had a complete response. Now, these were not surgical complete responses. These are radiographic and a biopsy. Biopsies, you can miss things. But still, 37% had a complete response. 63% had a partial response. So for those of us who have not taken math for a long time, 37 plus 63 is 100% had really good responding. That's a lot. So I will say you have to think about that as in the concept of what we normally see everywhere. And it is something you have to think that single institutional studies at tertiary cancer centers, the bias is that patients are a little bit better. And University of Chicago showed this years ago, where they looked at people who traveled a far distance to come for chemoradiation for head and neck cancer to those who lived in the local area. And actually, the further away you lived from the center, the better you did. And that makes sense. People who come from further away, they have better resources. They usually have less symptoms. They usually feel better. If you really felt sick, you wouldn't be traveling that far for treatment. So it is something that, at tertiary center, they have people that may be traveling from many, many miles away, sometimes other countries away. They're going to have better outcomes with it. So I always want to put that as always a bias with a single institution study, but still very impressive. And when you look at the outcomes from this, what you can see from those survival curves is that people did really, really well with doing chemotherapy by itself. One thing I never realized was that I thought once the people from MD Anderson who ran that study sort of, retired or moved on, they just didn't do this any further. Apparently they decided to do this study again. And of course they did it probably the right way to do it. They added immunotherapy to the chemotherapy. So this study that Renato presented, she gave a more traditional regimen of cisplatin docetaxel and added pembrolizumab to it. They gave 2 cycles, did a laryngoscopy. Progression of disease, you got standard treatment, whether it's chemoradiation or surgery, but something. If you had an okay response, so stable disease, partial response, CR, you then got 2 more cycles of this regimen, and then he did again an image and a biopsy. If you did not have a complete response, you got standard treatment. But in those who had a complete response, they gave 4 cycles of pembrolizumab alone and stopped. Now, these patients had to be watched closely, just like they did in the Anderson prior study. So they didn't do this and say, come back in a year. They were getting, scopes, and they were getting scans every 3 months. You had to come in quite frequently to make sure everything was okay. After 2 cycles, their disease control rate was 100%. So they did great. It's just like the other study. Like I said, maybe it's probably a patient selection bias there. After 4 cycles, though, the PCR was 78%. So think of that. With this regimen, 4 cycles, you have a complete response pathologically with the biopsy is of 78%. Now, remember, this is a biopsy. It's not a surgical resection. A biopsy could miss where the tumor is, but still really great. 11 of the 23, so almost 50% of these patients got treated with chemo alone. Means they never got surgery, they never got radiation, and at least in the group that got a complete response, pathologic complete response, only 7 of the 18 had a recurrence eventually. So they got really great outcomes. Only 1 patient so far has died with it, in this whole group of people that they did. The big caveat is look at the is follow-up. So our median follow-up is 20.4 months, which still is not that great. There's still this group of people who weren't even followed a year. So I think we still need to see later on. You really want to see what is that data at 5 years when all the people made 5 years. But right now, this looks like a very interesting study where you could give chemo alone and cure local regional disease and forget the surgery and radiation. Now, of course, if you're a surgeon or radiation oncologist, the first thing you say is, well, surgery and radiation has less side effects than chemotherapy, because that's what my radiation oncologists and surgeons tell me. But a lot of us think that doing the chemo, at least in the long term, probably will have less side effects. And it's an interesting idea that chemo could actually cure these patients. Next thing we'll talk about is this study that Ari Rosenberg presented from University of Chicago. And in this one, what they did was he took carbotaxol and nivo, it's a little bit different regimen, gave 3 cycles, and he looked for a radiographic response. Now, it's not the normal RECIST response, so they're not looking for 30%. They're looking for 50% or greater. If you had a 50% or greater, they did a response-adapted radiation. They changed the radiation fields based on what the tumor now looked like, and they decreased the radiation amount. If it was less than 50%, then people got standard chemo radiation. Now, you could argue a little bit that if you're less than 50, if you don't have a partial response, we know from induction chemotherapy that those patients usually don't do great with radiation, and maybe should have gotten some surgery. But there is a group of people who had at least a RECIST response, so it's not like that much of a problem. And then he gave 9 months of nivo. Why give 9 months of nivo after this? I don't know. I mean, that was one thing that impressed me about the lung cancer group, is that in lung cancer, when they're doing neoadjuvant studies, they seem to stop the immunotherapy after neoadjuvant. In head and neck, we keep doing this adjuvant part, although we've not seen that benefit from it. So you do sort of wonder, are we adding another variable, a variable that adds cost and likely morbidity to patients? So it's a real question why use that consolidation, but that was part of the study. Very good response rates. 89% had a response by RECIST, but in terms of their deep response, 54%. So a good response altogether. What's important is that the group that got a change in how they did the radiation, they had less side effects, because that's the whole point of this, is to see, do you have less side effects? And that's exactly what they showed, that you get less side effects if you have it. And if anything, it's quite a bit less. So there's a gigantic difference between the two groups. When you look at the outcomes, and this is a very, very misleading graph I'm about to show you, okay? So take that into account. They're looking at both groups, the one that got response adapted and the one got standard treatment. The response adapted did very well. 79% progression-free survival at 24 months, 86% overall survival. You can't compare these two arms. These are two different cohorts. If you respond to induction chemotherapy, you're going to do better. That is a better prognostic group. So you expect that group to be better. So this is not, by giving this curve, you can make the mistake thinking, well, then should be like the standard. That's not the case. You don't know in this better prognostic group, if they did not modify the radiation, that group would have done even better. However, it is at least a very good hypothesis generating data to suggest that this is something that should be looked at further. Because here you're seeing good outcomes and you're seeing good quality of life outcomes. So definitely a very interesting study. The last one, and when I put in like the beginning, like what my disclosures are, you have those disclosures, and I think that's what we always put in. This is the real disclosure of like where I might be biased, because this is a memorial study. So this is like that I was at least an investigator part of. So that's the one thing I want to add. If I biased or color this as this is an amazing study and you all should be doing this. That's not what I hope I don't bias it that way. But what this study did was looked at the same neoadjuvant type of treatment with immunotherapy. So cisplatin, docetaxel. For this one was cemiplimab. We also added cetuximab for this study. So basically throwing the whole kitchen sink right at the person. And these were all people who were going to have surgery, and everyone had to have surgery as part of the study. The difference was that after the surgery, people's pathologic staging was redone. And if your pathologic stage changed to the point where we would not, in standard practice, give you radiation therapy, you did not get radiation therapy, even if we're supposed to get adjuvant radiation therapy based on your initial stage. So that was a big difference. So we're looking at, can we get away with not doing radiation therapy afterwards? And they're also looking at, does it change surgery? Does that make a difference? Only 10 patients. So this is a small study. Almost all of them were oral cavity tumors. But what it showed was that the majority of them had some type of pathologic response. Now, this is different than the last two studies because this was not a biopsy. These people had surgery, so we know exactly what their pathologic response are. And in the group that's highlighted, those 4 patients, they did not get radiation. So almost everyone was downstage. 4 people who were supposed to get radiation did not get radiation therapy. What's at least made our surgeons more interested was actually the surgery changes. So before people had the induction therapy, you had to state what was going to be the surgery that was planned. And the 2 arms that really should stand out is the mandible arm and the free flap arm. In terms of mandible, you can see that 1, 2, 3, 4, 5 people who are supposed to have at least a marginal, if not a full mandibulectomy, which patients are not that crazy about getting, did not get it at all, and didn't have to have it. The other thing was a free flap, which that I have to say, I think is more of a surgeon to be able to tell you whether that's advantage or not. But definitely the surgeons say that's a big deal not to be able to do it. And in this case, 70% of people who were going to need a free flap did not have a free flap. And that actually is what got them more excited about the study as the study went on. When you looked at the outcomes, same thing as some of the other studies, it's one small. The other thing is it's not as long a follow-up as we really need to know for sure. But at this point, there has been no recurrences with a median follow-up of 16 months. And that definitely includes the 4 patients who never got radiation. So in summary, in 1991, the VA showed in the New England Journal of Medicine article the ability to avoid surgery, total laryngectomy, with a select group of patients with advanced larynx cancer by using this, start with chemotherapy approach. And in that case, if you had a good response, getting radiation instead of doing surgery at all, without affecting overall survival. Really, and there's 2 other studies that went to look at the same thing. But really, since that time, we have not looked at this real question again in the HPV negative population. But we're finally seeing in new studies a focus on either a modification of surgery and or radiation therapy with the use of using neoadjuvant treatment. Now, neoadjuvant treatment with immunotherapy attached to it. The real question exists now is how to move forward. Most of us are totally shocked that the VA study was ever able to be done. And most of us don't believe in the US that we would have ever been able to do the VA study where people were randomized to either receive to be able to possibly save their voice box to requiring a total laryngectomy if it was done in any place but the VA. So can we do like these type of studies where people are randomized to either receive a standard treatment versus something that may have a much significant better quality of life? We don't know. How to actually run the study is a bigger question, but eventually one of these 3 studies, if not more, all of these 3 studies will have to be looked at in a more randomized prospective fashion. Right now, they are just hypothesis generating. So the last thing we'll talk about is metastatic head and neck cancer. And for this, most of it is like you feel like you have to say something about this. It's, so I just couldn't like skip this altogether, even though there was no randomized phase 3 studies out there with it. But there was one very interesting study. So in terms of metastatic head and neck cancer, the way we treat this is based on Keynote 048. And that was a study that had a lot of problems in trying to analyze it in terms of like they changed their outcomes in the middle of treatment. They have this statistical design that that even the most advanced mathematicians don't understand. It was a complicated study with a lot of issues, but it changed how we do first-line treatment. So first-line treatment in metastatic head and neck cancer, if your CPS score is greater than 1, you get either cis-5FU with pembro or pembro alone. If your CPS score is 0, you get cisplatin 5FU with either pembro or cetuximab, but that became more standard afterwards. Adding chemotherapy to immunotherapy improves response rate. That there's no question about. The question always exists is in the CPS greater than 1, when should you add chemo and not add chemo if response rate's not like as important? So, like how does those things affect survival? So the group in I think it was France looked at this what we call a frail immune study, and this is in patients ineligible for cisplatin. Now, one of their definitions is you have to be over 70. So if you're over 70, you're considered ineligible for cisplatin. That's probably not how it works in the US. We give cisplatin to people over the age of 70, but like I said, in Europe, it's a little bit different. They also say if your creatinine clearance is between 40 and 60, you're not eligible for cisplatin. I definitely have sneak cisplatin when I needed to if you're a little bit less than 60, but that's a good definition. And if you have comorbidity, that's also a reason to be ineligible. And what he did was treat people with 4 cycles of carbo, taxol, and durva. Durva PD-L1 antibody. So a very reasonable regimen, and then you had maintenance durva for another 9 more cycles. So a very reasonable regimen that's probably a lot easier to tolerate than cis-5FU and pembro. The primary endpoint was 1-year-old versus 5-0. This was not a randomized study. And what you saw was very, very good results. A median overall survival of 18 months, 63% of people still alive at 12 months, 45% at 24 months. So the group felt very good saying here in this frail population, there looks to be a benefit. And that's basically their 1-year overall survival was met. Their objective response rate was actually 71%, with 7 complete responses observed. And if this shows survival is better if you had a higher PD-L1 status than a lower one. So a very interesting study. It's also like, I'll tell you, when this study was presented, 90% of us looked at each other for this. The reason why we looked at each other is not because here they were trying to do a study showing they could do something that maybe is less toxic than cis-5FU and pembro. But this regimen, these results are better than you see with Keynote-048. Now, it's not a randomized study. These are really, really, really good results. And that's way better than we see with actually standard treatment. So it really was an impressive outcome, but it's not prospective and it's not random. Sorry, it's not randomized, it's prospective. So it's not a randomized study, and that's the big problem. So in summary, very promising data using carbotaxol with immunotherapy. Data looks better than Keynote-048, despite it being a population that really should be worse. So this is a population that should be worse than the complete population that was looked at in Keynote-048. The thing is do we need a randomized study at this point? And that's the problem. So, it always not amazes me, but it makes me envious and jealous when you see the lung cancer data and when you see the breast cancer data, where you can do big randomized studies of 1,000 patients and actually answer very small questions to see, is adjuvant hormonal therapy going from 3 years and 14 days to 3 years and 18 days, better. It's amazing how you can look at these small questions and really answer things. We just can't do that in head and neck cancer. You try look at it's just not enough patients. A lot of the patients are not great candidates for a lot of clinical studies, although we need to do a better job in putting people in clinical trials. So the question is, do we have enough? Is this enough to move this forward? Or is this something that's really going to require a randomized study to do it? So when I was preparing this, what I usually do is I get my old slides and I just use that sort of as a skeleton and then put in all the new studies in. But it was interesting. I looked at my final remarks that I gave last year. And what I said last year was there any changes at ASCO that year? And there's really nothing. There's nothing that changed what we were going to do. I also said that the studies done in other countries may not completely reflect the North American population, and that quality controls need to be evaluated before we make changes in our practice guidelines when we look at what's been done in other countries compared to a US population. And that's sort of me being like very trying to be political correct with everything. My final remarks in 2023. Well, is there any game changers done in ASCO this year? I think we're still at the same point. So even though we have positive randomized phase 3 studies out there, probably the biggest change might be more that the carbotaxol of the single arm study. But right now, I think we're in the exact same situation that right now, the stuff that may be changing is on the smaller parts, not on the bigger parts. Do we use cisgem instead of cis-5U in the adjuvant therapy? I think now we at least have some justification to do it. We don't have to do it. Doing cis-5FU is not wrong. But at the same time, I think now if we want to use cisgem, we actually have a little more data with it. I think that we have data when we don't want to use cisplatin 5FU to say, okay, we got a phase 2 data with carbotaxol and durva. If the guidelines change in a way that we can use it, I think companion wise, we would probably be justified to do it. But there's nothing here that's going to really change our practice yet. The most enticing data we have is actually the dose de-escalation studies. Those are not ready for practice changing. So we should not, those 3 studies should not be changing how we do practice. Those 3 studies, though, need to be looked at in prospective phase 3 studies. And we have to figure out how to do those studies because that's going to have a major impact on our patients in terms of their quality of life and long-term benefit. But right now, we have to figure out how to do it and how to actually successfully approach those studies. So am I supposed to ask questions for this? Well, I don't know how the questions are supposed to be. I put them here. If you want it. So I put down my 3 questions at the end of my slide just in case. So the thing is, in nasopharynx cancer after concurrent cisplatin radiation therapy, cisplatin gem is superior to cisplatin 5FU for which ones? Overall survival, quality of life, progression-free survival, none of the above. Why everyone one time shout out their answer? 1, 2, 3. So it's actually progression-free survival. So we don't see the overall survival benefit or the quality of life, although we think quality of life is there, but it did show a benefit in progression-free. Induction chemotherapy and immunotherapy prior to surgery is what? Standard of care, but should be followed by standard surgery or radiation therapy. So don't change surgery or radiation. May allow for modifications of surgery and radiation therapy or an investigational. I'll say, do you want me to do 1, 2, 3? Anyone? Okay. It's investigational. So even doing chemo before surgery is investigational. There are early studies looking at this were all negative. The difference is we have better chemo now. We have much better stuff with immunotherapy and cetuximab. So this is even doing it before surgery is investigational. But these are things that really have to be looked at further because there really does seem to be a benefit in this area. And the last one, adding immunotherapy to neoadjuvant chemotherapy for locally advanced nasopharynx cancer, at least from the study, improves progression-free survival, improves event-free survival, improves overall survival, or has shown benefit in the US population. Anyone say D? C? Raise your hand if you say C. B? A. It's actually big. So when you do an induction, it's actually event-free. And I probably should have looked up the explanation or definition a little bit better, but we use event-free survival for induction. But that's just part of the thing. So I don't know if people have any questions. Yes.
So from practice, I had a patient 5-6 years ago, nasopharyngeal, got a standard treatment, surgery, cisplatin radiation, and relapse metastatic disease. So surgery was included something, but I could not get radiation because of some damage, and cisplatin because neuropathy and kidney joint. So it was I person came on paper, evolumab, and she's in remission. So the question, like with the lung cancer, since we made the first lung cancer, after 2 years, did I start evolumab? And there is no evidence of disease. He obviously is dealing with the side effects from, radiation, surgery, lots of problems which can affect quality of life. Fortunately, he doesn't have any trouble from we are approaching this 2 years, and more insurance companies are saying, 2 years we have to start it. How would you approach this?
So I'm in the same boat as you are. The problem is we don't have the data. The clinical studies all do things that are different than the way we do when we practice patients. It's the same thing with this cisplatin-based treatment. Like you do cis and gem, they stop at 6 cycles, but most of us gave gem afterwards and actually and did much better. So there's always a question, is like a problem with the studies is that they do things that actually often either borrow stuff from lung cancer, no offense, but the lung cancer data is like always like messes us up a little bit with it because we haven't shown it to be true in nasopharynx or head and neck squamous cell. But the immunotherapy thing is something that I run into like all the time. And it's always a discussion with the patient that probably the exact same discussion you have is we don't know what the answer is. The tendency always in my feeling is that if you stop the immunotherapy and it comes back, the immunotherapy doesn't work anymore, or rarely works. It sometimes does a little bit, but you don't see the same thing they had before. But if you continue doing immunotherapy, there's a point you're going to increase toxicity. The longer you do it, the higher chance you're going to have immune-related event. And are you really having any long-term benefit by continuing it? So I don't know the answer, and that's I don't know like that we're going to always borrow from lung cancer or from other groups, and I think at the end of the day we're probably going to most of us are going to start stopping in 1.5 to 2 years, but we just don't know the answer, and unfortunately I don't think that's ever going to be looked at in a randomized study.
But usually when it's like beyond 10 years, you really don't have like a major side effects, coming 2 years, except maybe hypothyroidism or something like that. But most of the time they do it okay.
Yeah, well, I guess we've been cluttered, but we have to, and I know also with some of the companies that they've actually seen like that the longer you're on immunotherapy, the higher chance you're going to get an adverse event. And we've definitely had a few late people where they did great for 1.5 years or 2 years, and then you start seeing something. Some immune-related event with it. So you get that risk as you go further and further along. And the question is just, is there a benefit to it? Because if there's a benefit, it's still rare to happen. Well, we just don't, that's the whole thing, we just don't know what the benefit is. But at the same time, there's a lot of other settings where we've stopped treatment way too early because someone made a decision that had nothing to do with science. It was, this is how it was done in other diseases. And like I said, I don't know what the right answer is, and usually I leave it up to the patient instead of making that decision myself. And and that's why it's harder when the insurance company tries to make the decision. I do.
Yeah, and it's easy when they have a second.
Yeah.
If they don't have a second,
If they don't, yeah.
and then all of a sudden they are still alive 2 years on their treatment and there's no side effects. It's difficult to
No, it's definitely hard, but also there's some people I have that are all they're feeling okay. Like you have different groups of people, and everyone's like has a different view of it. So that's why I let the patient make the decision and say, these are the pros one way, here's the pros the other way. I'm okay with either one because I don't know the answer, and then the patient makes a decision. And I've had both old and young patients who decide to stop after 1.5 years, 2 years, and I've had both old and young patients who have said, yeah, I'm doing great. I don't mind coming every 3 months or every 3 weeks, especially with immunotherapy, because you probably overdose immunotherapy in the first place. Yeah. So, if someone says, hey, I want to go on vacation for 6 weeks, I go on vacation. When you come back, I'll start it up again. It's still going to be in your body this whole time. So, I've become very loose about how often it has to be given later on for any type of event. But I do have people who just, you don't want to stop, and I'm okay with it as long as you know the risks and the unsure what we know about the data. Any other questions? Thank you very much.